Hey y'all, it's me, Dr. Smina Rahman, Gyno Girl. I'm excited today to talk to you guys about the conference I just attended. It's the International Society for the Study of Women's Sexual Health, ISSWSH. It is a conference that is geared toward the newest research and evidence surrounding women's sexual health. It is sort of the premier conference in sexual medicine for females or those that are vulvas. We have a great time. I'm going to show you some pics from that, but I just want to highlight some of the important things that we discussed and learned about and some new things that are up and coming. And then you guys can let me know if you want me to go into more detail on some of these topics. So let's get at it. Hey guys, back again. It's me, Dr. Smina Rahman, Gyno Girl. So I'm excited to talk to you guys today. Just as a reminder for those of you who are joining me for the first time, I am a sex med gynecologist and a menopause specialist in downtown Chicago. I have my own private practice where I see patients in my office. And please like and subscribe to my channel. I also have a podcast called Gyno Girl Presents Sex, Drugs, and Hormones. Please tune in. I have a lot of patients who come and speak about their experiences in the field of sex med, menopause, and other things, and sort of how they traversed and navigated and advocated for themselves. And I also have a lot of specialists that come on and discuss some of the latest and greatest. But today I want to talk to you about a conference that I just attended, the International Society for the Study of Women's Sexual Health, ISSWSH. ISSWSH is the premier organization for female sexual function and dysfunction. It is a multidisciplinary organization that includes clinicians, doctors, nurse practitioners, physician assistants. We have doctors that are urologists, that are gynecologists, that are internists, that are oncologists, a full range of family practice, all of the above, nurse practitioners and physician assistants. We also have wonderful pelvic floor physical therapists, we have sex therapists, we have psychiatrists, we have psychologists, we have patient advocates that attend. So it is really, we have researchers. So it's a wonderful organization, and we all put our heads together to talk about, some cases that we've seen, but also this annual meeting, which I'm a part of the scientific committee for that, and I'm part of the board of directors for ISSWSH, is an important meeting because we kind of talk about new things that we haven't discussed and how to navigate that as ISSWSH providers, but also, some of the latest research. ISSWSH is a wonderful organization. Just as a side note, it has an interesting start. It started around, I think, 24 years ago, and it started right after Viagra was discovered. So the OG, or sort of the godfather of women's sexual medicine, is Dr. Irwin Goldstein. You see him here with me. I've mentioned him before. He's a wonderful man. He and his wife, Sue Goldstein, that's her. She's also very wonderful. She's the president, or now the past president of ISSWSH, but they basically, are kind of like the modern day Masters and Johnson. But, he was on the original papers for Viagra when it came out in the 90s. I think it was 1998. And, when he would see patients in his urology practice for Viagra, their spouses would come in and say, hey, what about us? And, unbeknownst to him, they weren't being taken care of. So he and a lot of the colleagues that study female sexual medicine that he knew of around the world kind of started this collaboration. When I started the organization around 8 years ago, there were about 400 members. We've grown to about 1,500. So it's pretty exciting. People are really getting more interested, and there's a lot more research, and we need a lot more research. But some of the interesting things we talked about, I'm gonna grab my annual sheet to remember all the names. We had a very interesting discussion about sort of neurodivergence and sexual function and dysfunction. So we had patients that we actually had a speaker, Amy Gravino. You see her on her Instagram. She's a national recognized speaker who has a form of autism, and spoke about, the challenges that patients who are neurodivergent, challenges they face, sexual function and dysfunction, and the challenges they have seeking help from providers. We had someone talk about ADHD and how it kind of contributes to lack of sexual understanding and dysfunction. But you can follow her, Amy Gravino, when she talks about sex and the spectrum, autism spectrum. She's on Instagram and other things as well. And I think it's very interesting. This is an issue I can delve into and talk more about what she said, but it's really just sort of navigating the different issues that these patients face and how to better serve them. We had a discussion around diabetes and sex by Anna Marie Giraldi. She is from the International Study of Sexual Medicine, the ISSM, as well as she's a former ISSWSH president. She really delved into both type 1 and type 2 diabetes and how they're kind of understudied when it comes to sexual function. We know from sort of an overall picture, diabetes can affect your nerves and your ability to, desire sex with the fatigue associated with high and low blood sugars. We know that patients, some interesting things that they talked about with type 1 diabetes and how during sex, there's some concern about, getting too low in your blood sugars. There was discussions around how we need to work more with patients who have, arousal, orgasm, and issues surrounding libido for these patients because of the fluctuations in blood sugars. Sometimes when they have neuropathic damages to their nerves, their nerve endings. Of course, we always say in male sexual medicine that erectile dysfunction can be the first sign of what's going on with your heart. And so we look for hypertension, we look for cardiovascular disease, and we look for diabetes, because all of those can be affected by the small vessels that feed into the penis, and the same is for the clitoris as well. So there was also some discussion around how clitoral ultrasounds are now being used to assess vascular flow to the clitoris. And it's very interesting because the same can be said when you have diminished flow and then therefore orgasm and arousal concerns. It's also a vital sign for your cardiovascular disease. So I think that's always something very important to mention. We had another ISSM, Dr. Yakub Reisman, or Kobe Reisman. He discussed a sort of a multinational hypoactive sexual desire disorder survey that they had done through 6 different countries, over 5,000 people surveyed, because one of the big issues is, and I've talked about low libido on this channel before, with low libido, with bother, like you want to have sex and you can't, that's hypoactive sexual desire disorder. And I did a YouTube video on this. And the medications we use, other than hormonal manipulation, other than the biopsychosocial approach, we also use ADE and Vyleesi. Those are the trade names for these medications that work at the level of your neurotransmitters. And in Europe, we don't have those medicines. And so he was representing the European Sexual Medicine Society and talked about in this survey with 6 different countries, 89% of the female patients had low desire, and 63% of those patients with low desire had distress. And close to 50% would want to take medications if they, depending on the side effects, and over 50% had moderate dissatisfaction with their sex life. So it's a big problem internationally, and I think that we just don't give enough information and credit. So it's a big problem internationally, and I think that the point of the survey was to show the need for medications around the world, not just here in the United States. And it's really hard enough for those patients to get their meds covered, so I think that's another issue. We talked a lot about cancer. We always have a good discussion on cancer therapies and sexual dysfunction, which we always talk about. It's not enough just to live with cancer and to survive it. Patients want to thrive. They want to be able to have sexual desire. They want to have sexual function. They want to be without sexual pain, which we know some of these therapies can leave them with. And so what we do is we work with the oncologist. There was a rehab doctor talking about rehab and sex med after cancer therapy. So looking at surgeries, chemotherapy, radiation therapy, hormone therapy, how it impacts body image issues, the lymphedema that occurs from lymph node dissection, that swelling from those lymphatics getting surgically operated on, can really cause some body dysmorphia and some issues around pain. There's fatigue, there's low desire, there's neuropathic issues that come up from the damages from these chemotherapeutic drugs. And so there's a lot that we need to get into and we need to consider as sex med docs and providers. This physical therapist, Alexandra Hill, was wonderful. Here's her information. We talked also, Mindy Goldman was another person who talked about sexual function and the use of medications, the medications I described, and the use of therapy, sex therapy, vaginal estrogen, and even, inquiring with the patients who have metastatic disease, because they still want a good quality of life. They still want to connect, with their partners, and we want to do better for them. Back to the neurodivergence, I did want to mention Dr. Rebecca Kams, who talked about, how many women do have disabilities, 1 in 4, actually, some form of disability. We had a very interesting, full panel discussion on BDSM. So bondage, discipline, dominance, submission, sadomasochism. That's BDSM. So at the conference we had Debbie Hatter. She is a sex educator and researcher who came to speak to us, and it was very interesting because she did a whole segment on choking. Obviously choking is kind of more common than we realize in all of the pop culture. There's this song by Jack Harlow that my own children listen to about how, he's vanilla and he'll choke you. He's not a killer, but no whips or chains, but will choke. So I think the term vanilla is used a lot in some of these communities that, you don't like adventurous sort of sexual things. But, there was a study that was done with Dr. Herberneck as well as Dr. Feiner and some other individuals at the University of Indiana looking at frequency, method, intensity, and health sequelae of sexual choking among U.S. undergraduate and graduate students. And it is very surprising that with over 4,000 people that they randomly sampled, 2668 were undergraduates, 1576 were graduates, and it was a confidential survey done in 2021. The mean age of being choked first was age 19, with many of them, including undergraduates, stating that they had been choked in adolescence. Women and transgender, non-binary participants actually were more likely to be choked than men, and they most often used hands when choking. Mostly the response was pleasurable sensation or euphoria. That was up to 82%. A head rush was up to 43.8%. If you're wondering why people choke, if you're not into that. Feeling that they couldn't breathe, 43%. Difficulty swallowing, 38.9%. Unable to speak, 37.6%. Watery eyes. So there's things that come about when patients are choked within the BDSM and communities. And as healthcare practitioners and providers, we need to be aware of that so that we can better serve our patients. And there are consequences to chronic strangulation and choking. We did have a lecture on that, which I can discuss in more detail about the changes in your brain matter and function when you have chronic strangulation and asphyxiation. So, I thought that was something that was really interesting that we don't learn enough about. And so these are practices that I will incorporate more because some of the health sequelae are there and we need to know about them. We had Dr. Barry Kamurasak and Dr. Irwin Goldstein give a talk about orgasm dysfunction, and there is going to be a whole new orgasm process of care that comes out next year for ISSWSH. And the discussion was around how similar the orgasm and pain pathways are in our brain. And look, here's some imaging that Dr. Kamurasak brought in for the MRI images of patients when they're having orgasm. And here's a picture of patients that are in pain and or orgasm. They look the same. So the pathway is very similar. And so when patients have orgasm dysfunction, can either be never had an orgasm, can be that they are very close to reaching orgasm, but the genitals get too sensitive. Discussion around other sort of erogenous areas, earlobes, feet, that kind of thing. We had discussed that. When you have these patients with these dysfunctions, it's all about balancing your parasympathetic, sympathetic nervous system. We're looking at excitation and inhibition of brain signals and how to kind of control those. So sometimes if a patient has too much excitation, maybe too much norepinephrine, too much dopamine, we might have to give them something like a short-acting serotonin agonist, something that will decrease their excitation and promote inhibition, versus some patients who have the opposite. So I'm going to go into that a little bit more if you guys want to hear more about orgasm dysfunction, but we did have a great lecture on that and understanding how orgasm and pleasure pathways are very similar to pain pathways. We did a lot more discussion around hormones and how they're so important to our genitourinary system and pelvic pain, as well as we talked about pudendal neuralgia. We had a whole panel discussing different regions and approaches to that, from Michael Hibner talking about pudendal neuralgia surgery to Stephanie Prendergast talking about pelvic floor dysfunction and contributions to pudendal neuralgia, which is where your pudendal nerve that exits from your spine gets either entrapped or it gets irritated. There's something happening either in the spine or the or the buttocks. Patients that often, for instance, bike a lot, they might have pudendal neuralgia. So all of these topics I can go into more detail on, but these are kind of the things that we got some updates on at the ISSWSH conference, and I'm presenting you all this information so you can tell me in the comments like what you'd like to hear more about and what you want me to dive into more about. So again, we talked about neurodivergence and sexual functioning. We talked about cancer survivorship and sexual functioning. We spoke about and learned a lot about BDSM and kink and health consequences and prevalence rates. We spoke about alternative ways to deal with chronic pain. There was an individual from USC, I'll remember his name in a minute, but I'll post it, who talked about sort of virtual reality and its use in chronic pain disorders. And so a lot of interesting data is coming out, a lot of interesting things around orgasm dysfunction, like I said. And we also talked about sort of patient advocacy in the sexual medicine space. And then there was a discussion around religion, non-Abrahamic religions, and sexual function and dysfunction by Dr. Sonia Balani. That was a very interesting topic about how that religion intersects with sexual function and dysfunction, which we can go into on a separate video as well. But this is kind of a synopsis. It was a lot of fun. It was great engaging with other thought leaders in this space. It's a very multidisciplinary approach, as I said earlier. So let me know in the comments, do you guys want to hear more about one of these topics? Do you want me to delve into that in a deeper way? Because I'm happy to do that now that we have more information on some of these things. So again, this is Dr. Smina Rahman, Gyno Girl. Until next time, I'm going to talk a little bit about male sexual dysfunction next time, because that is something we got into as well. And so I hope that you guys got a little bit of a taste of what goes on at the ISSWSH conferences. A lot of fun. I mean, a lot of discussion around sex, so how could it not be fun? But, just learning some of the health consequences of some of what we do and learn about are very important for us as clinicians. So until next time, I hope to see you guys at my next episode. Please tune into my podcast. Please follow me on Instagram. Please like and subscribe to this channel, and more later. See you guys. Take care. Bye-bye.